weeks post-op. In regards to the fifth metatarsal resection with the baby toe, we call it a ray, which is a fifth ray resection. So that involves amputation of the fifth toe as well as the resection of the fifth metatarsal. I flapped it, closed it up, and as you guys can see, it's done and over with. This will continue to protrude. If I may put my finger over here, this is starting to puff up, and this will continue to puff up, and it takes a form, a shape, and for the most part, but that takes time. And overall, this is a phenomenal result. This individual has a high arch, which unfortunately led to pressure along the area of the baby toe and created the ulceration or osteomyelitis, but unfortunately created a very nasty infection that needed to be addressed and closed. In his situation, if he has a transfer lesion, if he gets a lesion right underneath the fourth, because now there's no number 5, then what the solution, either we address it in the forefoot. What more probably I would recommend is to address the foot type as a general. So therefore, address the calf, address the heel bone. If the heel is rotated in one position, de-rotate it and break it and reset it. And so therefore, the positioning and the weight distribution is proper. And so that, I think, would be best for him. We're going to try the orthotics with the filler. We call it a buttress, and proper shoes. And if it does work, wonderful, God bless. And if it doesn't, we'll have to address surgically to correct the foot and prevent abnormal distribution of body weight. So that's basically in a nutshell. So I just want you guys to see. So why am I taping the toes? Because the toe has nothing on the side. It can easily pull off. So what I usually do is just tape them together. So therefore, he doesn't stick up or become flail or floppy or dislocates. He can move up and become a problem or to the side. And so that's why I tape him. So anyway, this is the outcome again. And just want you guys to see what was the before and the after result. And the patient is able to walk without any issues. Thank you. This is the plantar aspect, which is the bottom view of the fifth ray resection. As we can see, it's starting to beef up and puff up on the side to try to take shape. My concern, as I was trying to explain to you guys before, when he starts walking, he's got a high arch foot, and the tendency, the distribution is usually on the outer part, and that's why the tendency of spraining the ankles, weight on the side, it's more of a C-shaped foot when they get out of the shower, when they step on the sand. So I'm want to keep an eye on this area as he starts walking more and more with the custom orthotic to see if that's causing any problems, any callus formation, pressure areas. Otherwise that will break down, and also then he'll end up with more resection, more loss, which we do not want to do. So in this situation, as you guys can see, the heel is rotated this way. I would cut it and make it more angled, perpendicular, so less of a curve. And what I usually do is get x-rays of the heel itself to see how much of an angle I need to reduce it and align it to the second toe and the second toe to the knee and the shin bone. So that's what I usually do from a surgical standpoint, from a correction and reconstruction. So that's the bottom part of the foot. And the foot on an x-ray looks like this. So that is what we have right now. And so again, I was concerned in regards to right here, if there's going to be pressure, callus, and ulceration. And as we see, this is the opposite phenomenon. Usually when people pronate, this becomes out. They call it escapes. In this situation, it's more in. So he's got a cavus foot, which is a high arch foot, which is very troubling because knowing the fact how these usually end up is continuation of pressure on the outside. So we want to prevent that. And so what I usually do is work on the calf, work a little bit on the instep as well, but mostly on the heel of rotation. So if it's like this way, we got to rotate the heel that way. So that's basically it. And just want to give you an update in regards to this fifth ray resection. And it looks phenomenal from our standpoint right now. So it's starting to beef up, but again, the pressure sores and callus formation, if that's going to become an issue, then it has to be addressed. Otherwise, he'll be ending up with further amputations, which is uncalled for. Thank you very much. Bye-bye. Okay, so diabetic foot infection placed her on a PICC line. Surgery was not an option for her, and so therefore the medical route was the PICC line. Diabetic foot infection. Obviously the infection is worsened, as we can see the abscess formation with purulent discharge, as we can see down in the pan, and it's still coming out. So as we squeeze it, you can see it's coming out. Yep, and as we squeeze it out, coming out. Okay. Thank you, Sue.